judgment, experience, and also respect to the uterine integrity. So today webinar, we focus mainly on the removal, right? And also it is a delicate balance between excellence and preservation of the uterine function. So every decision, every incision, every technique reflects the surgeon's expertise and commitment. So today, let's hear from the eminent speakers how the refined skills and also the thoughtful planning translate into an optimum outcome for our women. So with this introduction, I would like to welcome our President, Dr. Kalyan Bamade, to give away the welcome address, please. Dr. Kalyan Bamade, as you all know, is the current president of IAGE, and he was the secretary of IAGE, a very, very dynamic and young and very vibrant person, and of course, down
Thank
to
you, ma'am.
friendly. And of
Thank you,
course,
Dr. Mala, for this nice introduction.
now
Uh,
everyone must have known Dr. Kalyan Bamade, sir, and over to you for your address.
Thank you, madam. It is really nice to see Dr. Mala grow in our IAG, and she's a likely candidate for being a president in next few years. So this is a Scope and Trocar series, and it is the eighth episode. We conduct every month one webinar on Scope and Trocar and one only on Trocar. So this is the 15th webinar of this year. I'm really happy that my secretary, Dr. Sujal Munshi, and treasurer, Dr. Sejal Naik, are being instrumental in happening these webinars. I'm thankful to Dr. Malaraj, who is the convener and senior MCM members of IAGE. Today, we are going to discuss about myomectomy. We are happy to have Dr. Richa Pal, a youth council member, and Dr. Vijay Kumar, youth council member from Pune. We are going to discuss few topics which are very important and relevant in today's world. With the era of the robotics, is it really needed to buy a robot? Or even a laparoscopic myomectomy can be possible for all difficult cases, and that will be discussed by none other than stalwart Dr. Kiran Koilo madam, who is going to talk on advanced myomectomy in large and multiple fibroids. So anytime you are doing these myomectomies, the only question comes in mind whether to reserve blood, what to do, whether to give blood transfusion for this patient. So Dr. Pranay is going to talk on precision over perfusion, that is minimizing blood loss in myomectomy. And lastly, when fibroids break the rules, that is uncommon fibroids. And mind you, this is going to be a really good lecture, and all her videos are with laparoscopy because she has bought robot just 1 week back. So think over this, that even laparoscopic myomectomy is possible in the world of robotics myomectomy. And secondly, we have to get updated to the newer technologies, because ultimately what is important for us is the well-being of a woman. The pain she undergoes with the infertility, menorrhagia, and pain has to be reduced, and we have definitely myomectomy coming up as a help for these infertile and perimenopausal women. So today's webinar is going to be a really insightful for A to Z of laparoscopic myomectomy, and I again thank Dr. Vijay and Dr. Richa and our coordinator Dr. Malaraj for organizing this webinar. Thank you so much and welcome for the webinar.
Yeah. Thank you so much, sir, for your kind words. It is truly inspiring to hear from you. Of course, in the era of robot, now we are also sticking on to the laparoscopy, to the old guns, and then we know that this can never be replaced because robot has got its limitations, but laparoscopy is able to perform all kind of fibroids, which is not so in robot. So we cannot give up our laparoscopy skill for the sake of robot. So with this, we move on to our webinar, and for which we have our young youth council members, They are the potential talents of IAG, Dr. Richapal and Dr. Vijay Kumar. So Dr. Richapal, if you see, is a consultant of advanced laparoscopic surgeon and infertility specialist from Manipal Hospital, and she is also trained in robotic surgery and has a fellowship in advanced laparoscopy and reproductive medicine, as well as in ultrasound. And her areas of interest is endometriosis and infertility. And also, she is the state coordinator for the Foxy Endoscopy Committee. Has authored various chapters various chapters in various publications, and she's been an invited faculty in national and international conference. Along with, we also have Dr. Vijay Krishna Sathale, who is the director of the Onyx Hospital. Again, a very dynamic and young upcoming endoscopic surgeon, visiting laparoscopic surgeon in various hospitals like the Noble Hospital, Manipal Hospital, and also the Cloud9. Our youth council member and a life member of IAG and faculty in many conferences, and been awarded the Best Video Award at Yuva IAG Lathur. So we hand over the session to our young youth council members to introduce our chairpersons and to proceed go ahead with the proceedings. Yeah, Dr. Richapal, can you please introduce Dr. Priya Bhave? Dr. Richa or Dr. Vijay Kumar?
Yes, ma'am. I will introduce.
Yeah, please.
Good evening, all. I would like to invite and introduce Dr. Priya Bhave Chittawar, ma'am. She is consultant and head department of reproductive medicine, Her Health Bhopal, FNB reproductive medicine teacher, ex-faculty DM reproductive medicine, Foxy recognized trainer in basic and advanced infertility management, Cochrane reviewer and author, secretary MP chapter IFS, awarded for Dr. Pankaj Talwar Gold Medal at IFS 2022. Main important is she is Ironman triathlete, managing committee member IAG 23-24 and 24 to 26, first gynecologist to do telesurgery from Delhi to Bhopal, first gynecologist to do reciprocal telesurgery between Agra and Bhopal, first surgeon in the world to perform telesurgery from the Mantra M bus. And main thing, I had observed this surgery last one, that first surgeon in the world to perform telesurgery from Mantra Mbus. Welcome, ma'am.
Yeah.
Thank you so much, Vijay, for such a nice introduction. And my very big thanks to Dr. Kalyan for organizing this series. Each series is a gem which we want to preserve and revisit again and again with all the stalwarts. And of course, my favorite surgeon is Dr. Mala Raj. I have been following and learning myomectomy from her. And probably she is the myoma lady of our country because the kind of insights that she brings to all of us is just unparalleled. Today, it is really a privilege to introduce and to chair Madam Dr. Kiran Koelho Madam's session. She is somebody that we have looked up to, and she had done one. I think it was a Zoom meeting, which really inspired me so much in my own life. So ever since, she has been really a role model for me. She is the celebrity obstetric and gynecologist and laparoscopic surgeon. She is currently the head of the department at Lilavati Hospital, Mumbai. She is also attached to several hospitals, leading hospitals. And the biggest thing about her is that she is as skillful in obstetrics as she is in laparoscopy. Her passion is laparoscopic surgery. She has got trained from US, and in today's lecture we are really eager to see the wealth of the experience that is going to unfold in front of us. So ma'am, without taking much time, I really invite you, and I think this is one session which every gynecologist in India would love to visit again and again. Thank you.
Thank you so much.
Thank you, Priya, and thank you, Dr. Kalyan, and of course the dynamic Mala for inviting me today. I'll just share my screen. So Mala has given me a topic which is very dear to my heart because over the years I've been doing, I think now, laparoscopic surgery for 20 years. We were the first hospital in India, in Bombay, to get a laparoscope at Holy Family Hospital. I'm talking about maybe 20, 25 years ago. And thanks to the surgeons who were very active in buying one. So over the years, we know that women neglect themselves. They come with large and multiple fibroids. And today I'll be presenting some of the cases that I've found interesting. The hospitals I work, that is Leelavati, Hinduja, HN Hospital, and Hodi family. We all know the incidents, so we'll just quickly run through these slides, 50 to 60%. But do we have to operate on all of them? Not at all. It's only those who are symptomatic, and of course, with large and multiple fibroids, most of them are symptomatic.
Slide mode, ma'am. Can we go on slide mode? Slideshow?
Oh, you're not able to see the slides?
No, we are able to see, but it is on now. It has to come to the slide mode.
Okay. It's sharing, I think.
Slideshow, yeah.
Ma'am, kindly reshare it, ma'am.
Okay, we'll just
Stop share and then reshare it, ma'am.
Yes, we'll stop share and we'll share.
Yes, ma'am. Once more. Yeah. Yes,
Is that
ma'am.
okay?
Now we can see. Yeah, but
Okay.
now we have to start the PPT.
Actually, for us, it is showing like normal mode only, ma'am.
Yeah, नीचे वाला वो चालू कर दो, ma'am.
That means video will not show, no? That's it. Now is it okay?
Okay.
All right. So
That's fine, ma'am. You can go ahead. Yeah.
I can go ahead. So, you know, we know that the symptomatic fibroids are the only ones that we will tackle. And of course, with large and multiple fibroids, they are all symptomatic. So classification, we all know, I won't dwell on that. And what is important in, especially when you're dealing with large fibroids, multiple fibroids, is mapping. So mapping is the most important. And fortunately, now we have so many modalities where we can literally map every single fibroid and locate them so that they are all removed with one sitting, and the patient doesn't come back to us and say you residual fibroids or recurrent fibroids. So clinical assessment is, of course, the uterine size. Ultrasound 2D and 3D gives very good 99% specificity. Sonohistogram, MRI is invaluable for large fibroids, especially if associated with adenomyosis, with endometriosis. We have to map the fibroids. Hysteroscopy. These are the various investigations that we use for diagnosis. Now, the
Ma'am, your slides are not moving, ma'am.
Oh, now we are not in pre-operative evaluation? No.
No, ma'am.
Oh.
If you go to slideshow, it will automatically
Ma'am, go to the slideshow. When you want to come back, yes, now it has.
Yeah, I have.
When you come back to the videos, that time you can go out.
Okay.
The slideshow is there on top, ma'am. Just click on that, please.
Slideshow. Yeah, slideshow.
नीचे भी है, ऊपर भी है. Yes, ma'am.
Yeah. Oh, so quickly. Is that changing now?
No, ma'am.
Not yet.
I don't know why.
Go to the current slide. No, on top.
On top.
On top from current slide.
From current slide.
Slideshow from current slide.
From current. Now?
No, ma'am. We were not able to see, ma'am.
We're not moving, ma'am. Otherwise, you have to click on each and every slide for it to come.
Okay.
Ma'am, while sharing the screen, you need to click on entire screen option, ma'am, so that this error will not come, ma'am.
Double click.
I have Shailesh, he's my tech support, but
Shailesh, double click first.
Double click here, sir.
It's not come yet. Slideshow has not started yet.
Wait.
Oh, challenges in my.
Yeah.
Is it okay?
No, ma'am.
Not
have
yet.
you got figures up? No.
No. Your PPT has not started only.
No.
Yeah, share now, Shailesh, from
While
below.
sharing, you need
Share.
to click on the entire screen option, sir, so that this will not repeat it. Instead of clicking on the PPT tab, you need to click on entire screen and screen option on top.
Screen.
Screen. Entire screen.
And then share.
Share.
Now
Yes,
you
now
click on
go
from
up.
current slide.
The screen, na?
Slideshow.
Slideshow. Now
Slideshow.
Go up on the slideshow.
Double click now.
Yes, ma'am. Yes,
Yes,
perfect.
it has started now. Perfect.
Thank you, ma'am.
All right. Now
Yes,
it's okay,
Shailesh.
Karan?
Yes,
It's
ma'am.
showing
We can see.
keyboard classification. Is this the classification which you are
it's
seeing?
classification we are saying, madam.
Yes, ma'am. Yes.
Okay. So we just go ahead with the classification. Next would be, no, it's not going down. So I think you click, everyone. It's okay. We keep
Double
clicking.
click on the slide, ma'am.
Shailesh, open the PPT, minimize it first.
Yeah.
Open it. Now minimize it. Go to the share button now.
Wait.
Share.
Open. Full screen.
No, now we have to go to share button
Table.
below.
Share.
Very good. Yeah, go to the PPT. Very good. Start the slideshow.
Okay.
Yes. Now perfect.
Yeah, great.
Okay.
Yes.
Yes.
Thank you, ma'am.
Now it is working.
All
Yes.
right.
Yes.
So I'll just quickly now, we've lost time. So I was just talking about the mapping that I think I've already spoken. So these are the various points. Mala,
Yes.
I'll go ahead.
Yes, ma'am.
Pre-operative evaluation, of course, because we are dealing with these large fibroids, a complete hemogram, and we have to do the blood grouping, cross-matching, do ultrasound, map the fibroids, transvaginal ultrasound with color Doppler, again to map the number, size, and location of fibroids, MRI to rule out adenomyosis, also involvement of endometriosis, intravenous urography for displacement or obstruction to ureters is paramount, and whether there's hydronephrosis at all. Tumor markers, of course, and now since many of us have got 4K with ICG, we can also delineate the ureters by doing not a direct ICG intravenous, but doing a cystoscopy, ureteric catheterization, and then ICG injection. And that really delineates, and very, very important when we have broad ligament fibroids. Of course, we come to the goals. We know that we have to restore the anatomy, save the cavity, give good scar integrity with minimal desiccation, suturing and layers to close the defect and prevent hematoma is of paramount, minimize adhesions, and good surgical technique and perfect hemostasis. Now, the challenges we face are, of course, the size, number, location, associated adhesions, endometriosis, adenomyoma, and atypical fibroids. The challenges that we face with large fibroids are definitely inoculation, measures to reduce blood loss, which Pranay will speak about, suturing of the myoma bed perfectly, and the retrieval of the fibroids. Now, this is a case of a posterior cervical myoma. You can see there's a huge posterior cervical myoma. Now, when we take an incision over here, it should always be vertical, not transverse, because then it could extend into the ureters. I use vasopressin very freely, and I think most of us do, and gives very good hemostasis. Now, in cervical fibroids, especially posterior, you have to take the blood vessels and seal them as you see them, because if they retract, there's not much musculature in that area, and you'll get a big hematoma. So this was a very large, almost 14 centimeter cervical fibroid posterior. And as you can see, inch by inch, and all the blood vessels are sealed. And then with circular stitches, you can then reduce the bed and then suture, as you can see, and then the ureters on each side. Technically a little challenging, but can be done. So this is the end. With every procedure, of course, we will always check the ureters for their integrity and for their peristalsis. The next case is a true broad ligament fibroid. True broad ligament fibroids are very rare and they tend to grow very large. As you can see, this was a huge one of almost 24 weeks size fibroid. And you can hardly see where it's arising from the uterus. There in the corner, you can see the small uterus coming up over there, and the fallopian tubes, etc. And this large, very, very large fibroid, which is extended almost right up to the beyond the umbilicus. The usual adhesions. One thing about broad ligament fibroids, they are very, very easy to enucleate. They have no blood supply from the uterus itself, but only from the broad ligament. So as you're enucleating, you have to seal off all the feeding blood vessels, again, to prevent a broad ligament hematoma. And you can see with the traction, counter traction, sometimes you can use 2 myoma screws also to enucleate these fibroids. And they come out very easily, very satisfying for the surgeon, but one has to be very careful to seal the blood vessels. As you can see, this is a very, very large one. This is the bed with hardly any bleeding over there. The next is a large 28 centimeters broad ligament fibroid. So you can see this is the MRI report, and you can see it's right down up to the base of the pelvis, almost to the vagina, extending right upwards, and you can see the uterus with the uterine cavity on one side. Now, this patient, I'm drawing out the picture, it is quite large, almost 28 weeks size. Now, the challenges here are, of course, the anesthetist has to put in a Ryle's tube. The primary trocar is 4 finger breadths above the topmost summit of the fibroid. And of course, the secondary trocars are always put under vision. And here, this is the video of the case. You can see it's a very, very huge broad ligament fibroid extending right up to the lateral pelvic wall, huge feeding blood vessels. That is the the round ligament over here, right up to the side and extending posteriorly, also sitting on the ureters. Both the ureters were dilated, though the fibroid is on the left side. You can see here, a large broad ligament fibroid with a very broad attachment to the uterus. Now, you can give, in such a case, in this patient, I did do injection of dilute vasopressin, as you can see here, and that reduced the blood supplies somewhat. You can see it's rather blue here. Now, ideally speaking, you should take an incision on the most prominent region, but here it was prominent all over. So I started off with a incision on the anterior fold of peritoneum, just parallel to the round ligament, and with the help of a myoma's spiral, tried to enucleate the myoma, but it was very, very huge. So I had to use, and this 10 mm ligature is invaluable in these cases. So I cut open the round ligament and then only had access to the whole broad ligament fibroid. You can see a very vascular, large broad ligament fibroid, easily enucleated. Again, I use 2 myoma screws here so that you have traction, counter traction, and always being vigilant, because the base you can see of this broad ligament fibroid is literally sitting on the ureter, causing a slight ureteric dilatation also. And with each vessel that you see, seal as you go with a harmonic scalpel, as you can see. And every now and then, especially when you're towards the lower end of the fibroid, always look at the ureter. Now, of course, we can do a ureteric, maybe ICG dye, but these were the days before I had the 4K. And here you can see it's literally sitting, and that's the ureter, which is kinking down below. And this is the broad attachment to the uterus of the fibroid. And this attachment I then separated with, again, 10 mm ligature. Very, very vascular, large fibroid. And you can see the 10 mm ligature does a very good job in very, very hemostatically removing the fibroid. Slow and steady. Once the blood supply from the uterus is removed, then the rest of the fibroid, the one that is below, then I just lift it up, again, traction, counter traction, looking at the ureter every now and then, and remove the large fibroid. Here's the ureter now, absolutely safe. And this was the large fibroid which was removed. And you can see now the uterus has finally taken its normal size. This patient later on did become pregnant, and I did the delivery. Here you can see this is the base of the broad ligament where the fibroid was removed. And you can see at the base, you can see the uterine artery and then the ureter below. That's the uterine artery. And that's the ureter below. So it was not really necessary to line. Then, of course, the round ligament and be sutured, and you can see there's hardly any bleeding. If there is a little bit of bleeding, one can also put a Surgicel and then suture the anterior leaf of the broad ligament, the posterior leaf of the broad ligament. You can see that there is such good hemostasis that it's not necessary to pack that area also. So the most important factor that you do with the broad ligament fibroid is the ureter on one side and sealing the blood vessels so that there's no broad ligament hematoma. Otherwise, the patient will come back with a hematoma, and that's really disastrous. And here, this is the final picture. This were the days before in-bag morcellation, Mala. So these are all the morcellated fragments. Then we have a large 24 centimeter cavity deforming myoma. You can see this is the picture. The MRI and the incision taken. This is a huge fibroid, again, extending on both sides to the lateral pelvic wall. And so right in the center of the myoma, because the actual uterus cannot be made out, the fibroid is occupying the entire uterus, as you saw on the MRI, and both the ureters are dilated because of all the pressure. And the points that to remember here is good vasopressin, so that good amount of vasopressin so that you have less bleeding, and a large incision. Never stint on an incision. Make a large incision, because with that you'll have less trauma to the muscles, and also it's easy to enucleate without too much of pressure. As you can see, you enucleate as you go with a rock and roll method. You use a myoma screw and pull on the other side. And here is the large bed which is left of this myoma. And 3D laparoscopy is really invaluable because, and of course, I'm using barb sutures. And this patient I sutured in 5 layers. But with the 3D, it is so wonderful to suture because you can literally see each blood vessel and suture very carefully, because the most important in these large fibroids is to give a very good scar, and very scar which will not give away, because these are all young patients who want to have babies. So this was a 4 to 5 layer suturing, and that's the end. She had another small fibroid. So therefore, and this patient, it was too large even for in-bag morcellation. So what I did was extend. This is what I do very often now. Extend one incision, put in an Alexa bag over here, as you can see. All right. Alexa wound protector. And then after that, piecemeal take out the fibroid. And I think many surgeons are now resorting to this, because when you have very, very large fibroids, then again, putting it inside the bag and morcellating sometimes can be technically a challenge. Maybe the young ones will do it, but I'm still a little old school, and I'm technically challenged when it comes to these large, more than 25, 26 centimeter fibroids. Now, this is another one, which is, I think, 26 centimeters. You can see the MRI. It's really huge. 26 centimeter myoma. This is intramural, and it was, I think, on one side, as you can see. Again, very large myoma. 26, 20 weeks. Again, the primary trocar is The problem with the primary trocar being so high and near the xiphisternum are two. The stomach should be empty and you have to be careful of the arcuate ligament. Once you put in the primary trocar, then of course the secondaries are always done under vision. This was the hysteroscopy. You'll see it was cavity distorting. And this is the large myoma. Mala, you can tell me when I stop. I'm almost over.
Yeah, okay.
Yeah, so this is the large myoma. Again, you can see it's really huge. And it's on one side of the uterus. Again, both sides hydroureter because of the pressure. And again, with vasopressin. And this patient also, I think I had to open the broad ligament, cut the round ligament in order to enucleate this fibroid. You can see it's large with a little bit of soft degeneration also. Soft myomas are a little bit difficult to handle because they keep on troubling. But here you can see the entire myoma is removed. Very, very infrequently, hardly any case I've had to do uterine artery ligation or to reduce the blood supply, because usually with vasopressin, it works so well because by the time you enucleate and when you're ready to suture, then the supply just comes back. So you know that you're doing a good job suturing. Again, this with 3D and 3 to 4 to 5 layers of suturing in this patient, so that you get a very good integrity of the scar for her later on. This is a young patient. The next is a very nice case of a large multiple fibroids. This patient had a 36-week size uterus. And when I put in the laparoscope, it was like many people told her that you have to have a hysterectomy, but she was keen on having a baby. So I put in a laparoscope and you can see there are so many fibroids all over. This is another case, I think, of a broad ligament fibroid. Sorry. I think we have seen a lot of broad ligament fibroids. This is broad ligament, yes. I think I'll go on to the next for due to paucity. So this is a broad ligament fibroid where I found that the patient was very, very vascular. She couldn't afford to lose any blood. So in this particular patient, I went up to the brim of the pelvis, isolated the anterior division of the internal iliac vessel, and then put a ligature around it. And used, I think, shoelace stitch for this patient. Put in a small, as you can see, isolated it nicely and put in a stitch over there. And then temporarily you can then reduce the blood supply to the fibroid. Here, this is on the other side also. This I think many people do, but this I found like in so many cases over so many years, I've done it only in 1 or 2 cases because invariably you're able to manage with just vasopressin judicially used. So here you can see bilateral, and then the uterus becomes very less, the bleeding is reduced. And sometimes you have surgical surprises. Now, this was a very interesting case where it's very huge, right up to the xiphisternum, where she was diagnosed to have an ovarian cyst. And then when I put in the scope, couldn't see any of the anatomy, made a small incision and then drained out at least 2 or 3 liters of fluid, and only then realized that the anatomy. And this was surprisingly a subserosal fibroid which had undergone liquefaction and liquid degeneration of the fibroid. And you can see that's the base of the fibroid, which is a subserous fibroid, which was so huge that it underwent a degeneration, cystic degeneration, and the rest of the surgery was very simple. Anterior cervical fibroids are very, very dangerous because of 2 reasons. One is the ureter and the uterines are very close, and the bladder also is distended right up. So you have to be careful with dissection to go as high as possible. The bladder should be delineated at all times. And also the ureter has to be traced very well. Here you can see that's the uterine with the ureter below. And in this patient, I did a cystoscopy and did a stenting at the end of the procedure, just to make sure that there was no injury. Now, this is a patient who had the 36-week size uterus, and she was asked for a hysterectomy. She had multiple fibroids, but she was determined to have to retain her uterus. So I put in the laparoscope, and you can see there are huge fibroids right up to 38 weeks she was. And family of fibroids, there were subserous fibroids, there were intramural fibroids, there were fibroids upon fibroids, their family of fibroids, as you can see, all over. And so my plan was now to, because I didn't want to make a very, very large incision. So my plan was to put in vasopressin, take out as many fibroids as possible, and then after that proceed to do a small mini lap, so I could then take out all the fibroids and then do a suturing. As you can see, huge fibroids. So vasopressin really helped. And then it was literally like cherry picking, one by one, taking out all the fibroids with minimal loss of blood. You can see there are so many fibroids coming out one after the other. And later on, this patient went back to the UK and then had a IVF pregnancy at 38. So I was very happy. And these are the fibroids that I removed. Now, sometimes, and now more and more as I grow senior, I realize when you have young patients with large, multiple fibroids, rather than cherry picking, it is better to do a small fan and steel incision, take out and all the fibroids can be removed. This was a 21-year-old girl. As you can see, the uterus was bulky, almost 16 to 18 weeks. She had both fibroids and adenomyomas. She was only 21, family history of fibroids. I did a small fan and steel incision, took out all the fibroids. The advantages are here that you can palpate, you can remove all the fibroids, you can give a very good integral scar. So just because you can do laparoscopy is not a criteria. One should think of the patient and remove as many fibroids. There were 64 fibroids which I removed. So as always we know in surgery, first do no harm, and more so in cases like this. I thank you very much for a patient hearing, and Mala, I'm sorry for the disruptions. Thank you.
No, thank you so much, madam. So it was such an excellent presentation.
Yeah,
You
thank
have
you.
such a huge collection of cases, and it was really wonderful to watch everyone, all the surgeries. So there
Thank
are, yeah, Priya, can you please?
Yeah, sure. I'll take the questions. Thank you, ma'am. It was an amazing session. So not only did we see the skill, but we also saw your sagacity in, deciding and discernment. And I think that was the important message. There are some questions. One question is from Dr. Mrutyunjay. Uh, Good evening. This one, leiomyomatosis, did you put hysteroscopy? I think madam has already shown
Yes,
that she
I
did a
showed.
hysteroscopy, isn't it? Yes.
All cases were cases for who wanted to conceive, and all of them had hysteroscopy. I didn't show.
Right.
But all of
Ma'am,
them
Dr.
had.
Richa Roy is asking for 5 to 6 centimeter myoma. What is the volume of vasopressin and the dilution that you prefer?
I use 20 ml in 200 cc's of that, gives 0.1 unit per cc for the patient, and usually about 200 ml I use. That's the dilution.
Yeah.
20
But that depends. I mean,
in 200 ml.
in 200. Or you can use half the vial, 100 ml. It's the same thing.
Yeah.
Right.
Sometimes,
there's one question.
Yeah.
Yes, ma'am. Sorry, please continue.
No. Sometimes, if of course, with the way, so you're very careful giving it. I've never had an incident, fortunately, and I've been, now operating for so many years, almost 3-4 cases a year. I've never had a problem, but I realize you give a small, even if you do a dilution of, say, 20 units, one vial in 400 ml, it's still okay. Do it very judiciously and inject very slowly. These are the points that you should keep in mind when using vasopressin.
So you can also do the aqua dissection like how you are stating, ma'am.
Right. Yeah.
You
You can do an aqua dissection also. That reduces the amount that you have to use.
Yeah, when you are in, anticipating some kind of a risk.
Ma'am, Dr. Lavanya asks, what was the regarding the size of incision for huge fibroids for the port site expansion?
Oh, for that? No, not much, because the port site I used about, say, 10 to 12 port site. And then you use this Alexis wound protector. And once you use that, you can extend as you keep on rolling the wound protector. The incision extends and goes back. So it's not a large incision; it's an extendable incision, which then after that comes back. That's the advantage.
Yes, it's an amazing tip that all of
Yeah.
us got. Really, it is really a very important one.
For very large fibroids, believe me, I do a lot of impact, but I find it very challenging, quite frankly. And you've done so much of work, and at the end of it, you're going to struggle with this huge thing. I'm always nervous. So I prefer this.
Yeah, very true, madam. Yeah, it's a challenge.
Ma'am, any role of repeat vasopressin? That's another question.
If there are multiple fibroids and then I start with one side, I use vasopressin there, remove all those fibroids, and then go do vasopressin on the other side. Yes, multiple times I have used.
Yeah,
Right.
it's
But
always
what is nice about vasopressin is by the time you start suturing, the vasopressin effect goes. So you can get all the bleeders. So you're not leaving anything behind. And that's so important because you cannot afford to have a hematoma.
Yeah, so the half-life of vasopressin is only hardly 19 to 20 minutes. So that
Yes.
is why we inject multiple times. So we can finish one fibroid and then inject next on the
And
other
go to
fibroid
this.
and keep moving.
Ma'am, one final question on ICG use. How much ICG? How do you inject in broad ligament fibroids?
I don't use ICG at all. I have, except for if there are broad ligament fibroids with endometriosis. That's the only time I would use ICG. And ICG dry, again, if you give it intravenous, it only goes to the bowel, etc. You will not have any benefit. If you use it for CA cases, you have to give it intracervically, and then the lymph nodes are there. But when you want to delineate the ureter, the only way you can do it is by doing a cystoscopy, putting in ureteral catheters, and then injecting ICG. Yeah, ICG, yeah, it's a 25 milligram vial. 2.5 milligrams is the dose that you put, and it is 0.04 ml per kg of ICG dye.
Yeah. There is one more. How do you remove the soft degenerated fibroids?
Yeah, with difficulty, very slowly. Yeah, degenerative fibroids are a real nuisance.
Yes, those are the ones that in-bag modulation helps.
That really helps.
Yeah, so all the soft tissues get deposited at the bottom, so you can just pull out the bag along with them.
Exactly. And most important to use a bag there, Mala, because you can have a lot of seeding. Very often we are not so worried about sarcoma. We are more worried about leaving behind seeding, myomectosis. And I think that is the greatest advantage of the bag.
So in these situations, we cannot use even a myoma screw. So it is like rather than traction and counter traction, it is dissection. So in the
dissection, and I use usually a small little faucet like that.
Yeah.
Thank you.
Priya,
I
what
think
features most strongly influence your surgical planning, pore placement in large and multiple fibroids?
Sorry, what was that?
Yeah, preoperative imaging features that influence your surgical planning and a pore placement in large multiple fibroids.
Ultrasound, high definition ultrasound, and I do MRI. When you have large fibroids, MRI is invaluable, and I think it's a must. Because you have to rule out adenomyosis, number one, and number two is you have to delineate the ureters, and therefore MRI is a must.
There's a lot of people who are using a lot of medical management. So what has been your experience with the ulipristal? That's another question.
Terrible. Because ulipristal and all the medicine that you give, the medical line of treatment, makes it so hard to take out the fibroids. There is a dense fibrosis between the cavity, the pseudocapsule completely goes.
Yeah.
And we are depending on the pseudocapsule to give us a very good clean planes. And here the pseudocapsule is now completely adherent, number one, to the myometrium, and the other to the fibroid. So it becomes a literally a very hard, dangerous task to remove large fibroids in patients who have already had ulipristal. I think, Mala, is that the same experience that you?
Yeah, exactly, madam.
We struggle much harder when you have a case like that.
Never get the plane at all, and it is so degenerated. Very
It
much.
makes life very hard. Yes.
Better not to do anything. If you feel that the women also has some little more seedling fibroids, better to give post-operatively some medical management.
Absolutely.
And
But
not
you know,
immediately operate.
most women don't want to undergo surgery, and if someone gives them a medical line of treatment
Yeah,
and
very
tells them,
happy. Yeah.
they will go for that. And that's the reason why we have so many problems.
So that happens even with large fibroids. I'm very surprised. They'll have a big one sitting there, but still they'll be on medical management.
Yes.
It's really surprising.
Because if a baby can grow for 9 months and then, they have no discomfort, fibroids also grow.
Correct.
Especially.
Counseling them only takes most of our time.
Really.
Thank you, ma'am. It was such an insightful and wonderful session, and especially your small tips, your experience, it really showed through the videos. Thank you very much.
Thank you so much.
It's a really important topic, madam, and you covered and addressed it so well. Thank you so much for your valuable time.
Thank you. Okay,
So
thank you.
we move on to.
My RMO says.
Thank you.
Patient is 9 centimeters.
Oh, yeah, please carry on, madam.
No, I'm here till she calls me.
Okay. So thank you so much, Dr. Kiran Koila, madam, and Dr. Priya Bhave for this excellent session, making it very, very informative and also interactive. So we move on to the next topic. So can Dr. Richa Paul call over the chairperson, please, and introduce?
Yeah, a very good evening to everyone. So it's my pleasure to introduce Dr. Ramana Devi Madam as a chairperson for today's webinar. Madam is Medical Director and Head of Department at Sri Ramakrishna Medical Center. She's a director at Jenny Fertility Center, Trichy. Madam was National Vice President FOXY 2020. Madam was also Governing Council member of ICOG 2018 to 2020. She was the President of Tamil Nadu Obstetric Gynecology Society 2024. And Madam was also Chairperson of Endometriosis Committee FOXY 2014-2016. Welcome you, ma'am. Please.
Thank you, Richa, for your kind introduction. Now, Sagiti, please share the CV of the speaker. I'm happy to introduce Dr. Pranay Desai, who is a young and dynamic endoscopic surgeon. He is a consultant gynecological and laparoscopic and hysteroscopic surgeon with a special interest in endometriosis and a cosmetic gynecologist also. He is from Nirmala Multispecialty Hospital, Mahalakshmi Breach Candy Hospital, Bhatia Hospital, Saifi, ASI, Columbia Hill Hospital, and Wokards, and so many other places from Mumbai. I invite you to give a talk on where skill meets present. That is the important topic in today's webinar. Over to Dr. Pranay. Kiran, your talk was superb.
Thank you so much, Dr. Ramani. Very sweet.
Dr. Pranay? Oh. Dr. Pranay, are you there?
He was there, no?
Yeah, just now he was there.
Yeah.
Yeah, let me check. He was here all the while.
Yeah.
Yeah.
Welcome, Pranay.
Yeah.
Yep.
So we lost you suddenly. Yeah.
Sir, you're not audible, sir.
Yeah, you're not audible.
It's muted, I think. Muted? No?
No. Only now
It's muted.
Yes.
Only now it is okay.
Oh, we can't hear you, Pranay.
Try something. Am I audible now?
Yes,
Yeah,
sir.
now we
Yes,
can.
sir.
Yeah, you're audible.
Yeah.
Yes, I was just saying a beautiful talk by Madam, and it's always very difficult to give a talk after Madam to fill in those shoes. I thank Dr. Kalyan Bharmade, Dr. Malaraj, Dr. Sujal Munshi, and Dr. Sejal Naik for giving me this wonderful opportunity. And it's my utmost honor to give this talk amidst such, such fantastic dignitaries and faculties present here. So I'll just share my screen. I have to share the entire screen is what I was told. Okay. Play. Okay, is my
Yeah,
okay,
it
perfect.
was
It is visible. Yes, yes, very nice.
All right. Thank you, sir. So I will be giving a talk on minimizing blood loss in myomectomy. I have no conflict of interest. Now let's jump right into it. Let's try to find out the challenges of hemostasis and why do we find so much challenge while controlling blood loss in myomectomy. One reason is because the uterus doesn't have a single blood supply. It has blood supply from 3 vessels. One is from its own uterine artery, which is a branch of the internal iliac artery, but it also receives blood from the ovarian vessel through the uterovarian anastomosis, and also the vaginal vessel, which gives its blood supply through the vaginocervical vessel anastomosis. So the uterine artery then goes inside the uterus through the arcuate artery, which pierces the myometrium in the form of the radial artery, which finally goes to the endometrium through the straight and spiral vessels. Now, when there is a fibroid in place, this distorts the anatomy in such a way that the vessels have to actually go around the fibroid. And while going around the fibroid, they also supply blood to the myoma. That brings us to the concept of pseudocapsule. Now, what is a pseudocapsule? Pseudocapsule is nothing but the stretched out myometrium and the connective tissue around the myoma. And the Doppler studies have confirmed that the pseudocapsule is actually an integral part of the fibroid, and it is what contains the vascular supply to the myoma in the form of the ring of fire. And these perifibroid capsular vessels are the ones who are the dominant blood supply, and they have a very significantly higher peak systolic velocity as well as maximum average velocity and pulsatory index as compared to the vessel which is actually going inside the myoma. Now, keeping this concept in mind, there are a lot of papers which suggest that we should do an intracapsular myomectomy. So what they say is we incise the pseudocapsule, reach the myoma directly, and perform an intracapsular myomectomy to have the most efficient and bloodless surgery. And they also argue that the problem is not to reduce the blood flow to the fibroid in the form of giving vasopressin or uterine artery ligation, but to selectively coagulate the vessels that vascularize the fibroid during enucleation. And this pseudocapsule also is very rich in nerves, and there are a lot of genes that get expressed in the pseudocapsule which are important to heal the myoma bed. So this is another reason why we should actually save the pseudocapsule and perform an intracapsular myomectomy. So our goal in myomectomy is to do a preventive hemostasis rather than a reactive hemostasis. So let's see how we can do that by optimizing a few things. Firstly is the pre-operative optimization. We know all this, but we should definitely correct anemia in the form of giving intravenous iron therapy or blood transfusion to build up the reserves. We also need to keep blood ready in case we have a lot of bleeding during myomectomy. Now, GnRH agonist, which we just discussed, or medical management for fibroids, can be tried 3 months preoperatively. These reduce the volume as well as the vascularity, but it's extremely difficult to actually perform myomectomy after giving medical management because the cleavage plane is completely lost. Third is a vaginal misoprostol, which can be used. And there are a lot of papers which suggest that 400 micrograms given 1 hour prior to surgery brings about myometrial contractility and reduces bleeding. Now, how do we reduce the blood loss intraoperatively? With the use of our most favorite drug, that is vasopressin. And we have extensively used this. I will go on to this video and speak about vasopressin. Now, before I speak about vasopressin, when we inject it, I recommend the use of the visual vasopressor injector needle, That's the easy view needle that I'm demonstrating here. And I feel utmost pride to say that this is actually an invention by our very own Dr. Sanket Prasad. What this needle does, that it has a transparent window. So as soon as we aspirate before giving the injection needle, if there is even a drop of blood, it will be caught in that transparent window. And this way we minimize our intravascular injection of vasopressin and thus decreasing the amount of complications. Now, where do I inject the vasopressin? I inject it in the myometrium. I don't inject it over the pseudocapsule, but I inject it in the myometrium. So this will constrict the radial arteries and decrease the blood flow to the myoma. How much do I inject? So it's already been discussed. I inject about 10 times the amount of the size of the myoma. So if the fibroid here is, for example, 5 centimeters, so then I'll inject about 50 to 60 ml of vasopressin. The dilution is 1 ampule in 200 ml of normal saline. Now, this is another video where I'm showing that you can see that the blood can be is being seen aspirated in the injection needle. And when this happens, this gives us a clue that we are in the vessel, and hence you have to flush it out and re-inject at another position. So this is the advantage of using the needle. Coming to how we can control the bleeding using vascular techniques. There are two methods. One is temporary ligation of the uterine arteries using either the trick knot, shoelace knot, or bulldog clamps. What they do is reduce the pulse pressure, bring about a dry field, and these can be reversed after suturing. The other method is permanent ligation, and this is reserved where fertility is not a priority, or in cases where there is a risk of having recurrence of the myomas. So I'll speak about the trick knot, which is a modification of the shoelace knot. And this is what Dr. Sanket Prasad and I have published in the Journal of Minimally Invasive Gynecology. So the shoelace knot that Dr. Sanket described was using a loop of thread to tie an incomplete knot, which when tightened, ligates the artery, but this vessel can be easily reversed, the ligature can be easily reversed by pulling on the free end. But it can be challenging to form a loop using a loop of thread. Hence, I demonstrate a trick knot where I use a single thread of 60 centimeter number 1 polyglactin suture material, and this is passed through the skeletonized uterine vessel at origin. And like we would perform a regular intracorporeal knot, a single loop of thread, a single throw is taken, and instead of pulling out the entire thread, I pull out a loop of thread, which we can see that I'll be demonstrating here. So a loop of thread is pulled out, and when tightened, it easily ligates the vessel. And this vessel now can be easily reversed by the free thread, which I'll demonstrate here. So that's where I'm ligating the left uterine artery as well. So once the myomectomy and suturing is completed, the suture can be easily reversed by pulling on the free end of the thread. Now we know, like I already said, that the uterus has multiple sources of vasculature. Hence, we can perform the trick knot or the shoelace knot at the infundibulopelvic ligament as well to reduce the blood loss further. Now, this I recommend only in cases where there are multiple large myomas, not in all cases. And here, the only note is to take 2 throws when we are ligating the IP ligament temporarily. This way, the knot actually sits and doesn't slip off. And it can be easily reversed by pulling on the free end again. Similarly, the same reversible ligature can be done using clips, metallic clips. These are available in the market, only at a premium cost, but these do the same thing. Now, coming back to the concept of the pseudocapsule, like I mentioned, it's very important to stay intracapsular and to preserve the pseudocapsule. So I'll speak about these points while I demonstrate this through a video. Now, while I'm demonstrating this, I would also like to speak about how we plan the incision in a myomectomy, which also helps in decreasing the blood loss. Now, if we are going to suture intracorporally, but through contralateral manner, it's useful to have a vertical incision on the myoma. Whereas if you're going to suture ipsilaterally, how I would be doing, it's easier to suture a horizontal or a slightly oblique incision. Now, this incision should be as long as or maybe a centimeter short of the size of the phytoid. And once the incision is taken, what I do is I keep going deep as possible in the same plane till I reach the glistening white fibroid. And I use just the scissor and the myoma screw. I don't use any energy unless there is a sputter where I use a bipolar. But just with the scissor, I'm able to reach the myoma bed. Here you can see slowly and gently, with patience, you will reach the myoma. And hence you're actually incising the pseudocapsule only at one layer and not at multiple layers. And thus you're able to reduce the blood loss. So that's where we have reached the myoma here. Now I'll just fast forward for the interest of time. And as we give more and more counter traction and with the help of the myoma screw, we start seeing these vessels which start piercing the myoma. So these can be easily incised, staying close to the myoma and not close to the myomectomy. This way, again, we are preserving the blood supply to the uterus and preserving the pseudocapsule. Just fast forward again. So I'm staying flush to the myoma, and you can see actually that there isn't a lot of blood loss. That's also because of the vasopressin, but you don't see a sputter that you would otherwise see when you would incise the pseudocapsule. Next, coming to the closure techniques. Now, our goal is to obliterate the dead space and to prevent hematoma. And we do this by a layered closure technique, either using interrupted or using a continuous technique using the barb sutures. Now I'll demonstrate this with the help of a video. So I almost always take a horizontal mattress suture at the base of the myoma. And how I do this is going from the serosa, so that's outside to in, going as deep as possible, reaching the bed of the myoma, and then coming exactly on the opposite side, going inside the bed, and then coming out on the serosa on the opposite end. This horizontal mattress actually helps to decrease the blood loss, because what this will do is completely obliterate the base of the myoma, especially we have a lot of bleeding from. So now I come back. So I'm using my non-dominant hand to suture. This is the excess pseudocapsule that we had. And then patiently, trust me, this takes a little longer, but what it helps is that it decreases the blood loss tremendously. It decreases your pressure as well while suturing, because you don't see a lot of bleeding happening. So just fast forward for the interest of time. So suturing, I take 3 throws, because this way the knot doesn't slip off and I don't need my assistant to step on the knot. So this is after completing the horizontal mattress suture. Now, once the horizontal mattress is completed, the above layer can be either sutured using barb sutures or interrupted using the same white layer. Now, coming to the vertical mattress, also known as the Lambert stitch. Now, what this is slightly different from the regular figure of 8 stitches that a lot of people do. What is a vertical mattress? In a very similar manner, how we would do a vertical mattress over the skin. I perform this vertical mattress, so going away from the incision site and then coming out into the serosa, but close to the incision. So here you can see I was overshooting. I come back and I come out through the serosa. And then at the same level, so I enter the serosa close to the incision and then come out further away. Now, why this suture really helps in controlling bleeding is because it inverts the serosa inside and compresses the myometrium. So naturally brings about a very good hemostasis. And what it also helps is it helps in preventing, because there is no myometrium, residual myometrium from inside which is exposed. There is no excessive bleeding that you can see. So that's the first stitch. And I'll just fast forward. So that's once I've completed 3 vertical mattress sutures on the myoma bed. And you can see there is almost no bleeding and a very good approximation of tissue. Finally, coming to the barb sutures. Now a lot of people have moved on to the barb sutures, and it is a fantastic suture material because the advantage it brings as compared to the non-barb ones is that these, first of all, are knotless sutures, so you don't really have to take a knot. And number 2, it provides a continuous and even tension on the suture line. And hence there is not a single area which is left where a hematoma may develop later. So the barb sutures, again, you can suture in multiple layers. So you start at the base in one suture, then you can come back in the second layer. And in the third layer, you can do the baseball suture. That's the inside out manner. And what this does is it gives a very good approximation, and very few barbs are exposed in the baseball stitch, and hence the adhesions are also quite preventive. So in conclusion, hemostasis in myomectomy can be achieved by these 4 rules. 1 is inject vasopressin. 2 is to occlude the uterine arteries when required. Dissect, so that's dissecting intracapsularly, respecting the pseudocapsular plane, and suture in a multi-layer using barb or even simple vical sutures. And I end my talk by this quote by none other than Professor Charles Coe, who is the father of intracorporeal suturing, that adept and successful laparoscopic suturers are made and not born. Thank you so much for your patient hearing.
Dr. Penoy, it was an excellent, crisp, simple, and very informative presentation, I should say, right from the pre-operative preparation. I agree, we have to correct anemia at any moment. And you have clearly mentioned out that there is the role for pre-operative GnRH analogs and everything is going to be very, very, it's not ideal because you don't get the plane, or sometimes the myoma becomes necrotic and undergoes cystic degeneration. Then one more thing is for the blood loss, to prevent blood loss, you have mentioned specifically about the pseudocapsule, which I think everybody should know when they are doing their myomectomy, because definitely interfering with the pseudocapsule doing cauterization will definitely hamper the blood flow to the residual myometrium. And again, it becomes messy, and the hematomas usually occurs only when you handle that improperly. Then again, the point which you have in the information, that is the angiogenic gene expression is more expressed in the pseudocapsule. That's a very nice point because that helps in healing of the scar. especially when we are going to do it for an infertile patient. I think that is a must. And then vaginal mesopressed, of course, it does help. And definitely everybody should be, we are all using vasopressin to reduce the blood loss. And again, the needle, what you thought that what you had shown, that visible needle is quite safe because it can prevent accidental injection of this vasopressin into the vessels, which is very important. And you have given the quite in detail about the dilutional factor, and then comes the occlusion of the feeding vessels, especially these three vessels, infundibulate pelvic ovarian and then the uterine. All those two are very, very important. And of course, we cannot do much about the vaginal unless we go in for a ligation of the anterior thing of the internal iliac artery. That is quite difficult, and I don't think we need that at this moment. And MRI is a must before planning for any myomectomy, because the routine ultrasound may give a definite some of the points, but 100% MRI can help us to identify so that we can plan our treatment. And I think the suturing, what you had shown. See, in open surgeries, in those days, we used to do only horizontal matters first. Then only we go for the suturing the vertical matter. The same thing we can apply during a laparoscopic procedure also. Then again, the bar sutures have changed the scenario totally. And especially in-depth closure, 1 or 2 layers followed by base pulse suture. That's the norm for today in any myoma closure. I think in general, you have done a good job and it is excellent. And I congratulate you for your presentation. Any chat box,
so much,
will
madam.
be questions.
Questions are there.
Yeah, questions. Vasopressin, the most consistent peripheral, which they have asked, which will be the ideal one. What you prefer, whether you want to go for a vasopressin or ligation.
So, madam, actually, there is no doubt, and that vasopressin is the first choice because that's what easier and faster to perform. But I do temporary ligation of uterines, especially when there is a very large myoma. So, for example, a myoma which is more than 7 or 8 centimeters, I do tend to take the uterine arteries temporarily. Also, when there are multiple myomas, and especially I found this to be useful when the myoma is placed laterally. So a lateral wall myoma, either a left lateral or right lateral, but they do seem to get a very rich supply from the uterines directly. So hence, taking the uterine arteries at that position really helps. But yeah, there is no doubt. It's vasopressin comes first, and you don't need to take uterine artery at origin in smaller myomas.
Agreed. Yeah, there is this question. I think they have answered whether we can repeat vasopressin. Yes, definitely we can repeat vasopressin. You can inject for one myoma, remove it, and then the next you can inject, and slowly one after the other we can remove, thereby avoiding the bulk load of vasopressin into the system.
Correct.
Yeah. So that's a great presentation, Dr. Pranay. Very well covered all the surgical aspect and also the pharmacological aspect. Also, you have highlighted a little bit. But of course, when it comes to hemostasis, I think it is the surgical aspect. The vascular factor is what which plays a very major role in securing hemostasis. And the various methods have been very beautifully. A trick knocked is really a trick. I think that is beautiful, and it definitely it makes your life a lot more simpler. And also, in certain multiple fibroids, it's really helpful. And as you mentioned, in the lateral wall fibroids also. And the most important thing is what we should understand is like when it comes to hemostasis, it is better we rely only on the vascular factors rather than that on the energy sources. There is no point in just using so much of bipolar or the monopolar and going on cauterizing the myometrium and damaging it, because more energy source you use, they cause necrosis of the myometrium.
Becomes weaker.
And it hampers the integrity of the suture site. So that is the reason we have to rely more on the the vascular method, and it is always a good practice to learn uterine artery ligation at origin, because not necessary, as someone has asked, it is mandatory for all the cases. But then in simpler cases, if you are going to do, then definitely when a complicated cases arises and when the situation is needed, then it will be of use to us, so that by then you would have mastered the technique. So that is why. And whether it is going to be just the ligation or the vasopressin, in certain scenario, I think we need both of them. But many times we can also do away with vasopressin without doing ligation, but you cannot just like that rely only on the ligation, because as you have mentioned, there are, as we all know, the collateral vessels are going to be there. So just with ligation, you may not be able to complete your myomectomy, but with vasopressin, you can still go ahead and complete your procedure. So, but it is a good practice to learn that particular technique of ligation at origin. So these are the very important points, very beautifully highlighted with excellent videos. And of course,
Mala, there is one more question
yeah, ma'am.
in the chat box. They want to know whether you should close the endometrium if the cavity is accidentally opened.
Yeah, so it is
No,
not.
madam.
No.
Over to
See,
you.
I find post-operatively, if you are going to do a hysteroscopy in patients who have got the endometrial suturing, they have more of fundal fibrosis rather than patients who doesn't have, because natural healing is always better.
Especially
you don't
when
want to
you're
have a
using
foreign
barbed
body. Yeah.
sutures, especially in the era of barbed sutures, where they are not getting absorbed. So I think if you're going to take a bite on the endometrium, that's not going to be a good factor for our embryos. So I think it's not a good idea to suture the endometrium. Always just approximate the myometrium over the endometrium.
That is enough.
Very well. That is, the endometrium regenerates within 30 days. So there is no question of, and also there is a risk of causing iatrogenic adenomyosis when we are going to do a suturing in the endometrium. So these are the reasons why we need to avoid. And beautifully, the pseudo capsule has been highlighted. I am also very fond of the pseudo capsule. I just make sure it has to be an intracapsular myomectomy. I make sure that I identify the pseudo capsule and go inside the pseudo capsule. I constantly keep telling this one point. Pseudo capsule has plays a double-edged. It's like a double-edged weapon. So when it is present with the fibroid, it is anti-fertility. It causes so much of irritation to the junctional zone and interferes with the implantation. But once the myoma is removed, the pseudocapsule becomes a pro-fertility agent, because all the neurovascular peptides, the growth hormones which are present in the pseudocapsule, enhance the healing of the myometrial bed. So if we have to, this is the most important structure which we need to identify and preserve it, and also maintain it and give due respect to the pseudocapsule. So that is the main key when you do a myomectomy. I keep telling all my fellows who keep coming here.
Then what is the role for persistent?
Okay.
I've learned it. I've learned many years back. I think I've seen you doing a live myomectomy and using the barbed sutures. So I've learned from the best, madam.
Thanks. Now you're gone somewhere, Pranay, beyond everyone. Okay, so that was an excellent session. Thank you for making it very interesting. Excellent. Thank you, Ramni Devi, madam. It was wonderful having you. You have summed up so beautifully every aspect of his lecture. You have made it a point and you have highlighted it so very well. And thank you so much for chairing this session excellently. And
Madam, I don't, sorry to add, but I don't think we need ChatGPT to summarize the presentation. We have Ramni Devi madam who has done it so beautifully.
Thank you so much.
Very well.
No, just one question. Can I just take it? It says, do I use Surgicel after suturing routinely? No, I don't. Only if there is continuous ooze or bleeding, then, a little bit of ooze, then I would use Surgicel, but not otherwise. And if the delegate asks about Interseed, then Interseed is to prevent adhesions. Madam, honestly, I've used Interseed very rarely, and I don't use it that often. If the adhesions are going to form, they're going to form either way, with or without the Interseed. So it doesn't really matter. What matters is to have good hemostasis, good approximation of tissue.
Yeah.
and
So,
good surgical principles. That's what
what?
matters most.
Now, yeah, can I add one point? Because I'm very, very fond of Intercid, especially for nulliparous fibroids. I make sure that I put Intercid because, we use barb sutures. Okay. We know like barb sutures cannot cause any obstructions or anything, but then the barb sometimes can irritate and can, attract those bowels. So this
Correct.
Intercid, not only for adhesion barrier, it also act like a shield and keeps the bowels
Right.
away from that of the raw area. So in that way, Intercid, especially for nulliparous myomectomy, I make sure that I put the Intercid. But very important, we have to secure hemostasis. Otherwise, it is going to go anti-adhesion. So it will attract adhesion. So because sometimes people get confused with Surgicel and Intercid. Both are reactive oxidized cell. But the oxidation is occurring at various different level. That is why the mechanism, sorry about my throat, mechanism is very different from both the things. So you should never get confused between Surgicel and Intercid. But there is one powder called the 4-dry powders. All these Surgicel powders are there. So those things, in fact, they have both the actions to play. They have both hemostasis mechanism plus also adhesion prevention. So those things can be used if you're having slight ooze. But when you're using Intercid, make sure it is completely nice and clean and dry, and there is not a single blood.
Okay. Thank you, Mala, for making me a part of this wonderful
Thank you,
webinar.
It's
Thank
an
you
honor
so
having
much.
you with us, madam, and for sharing your knowledge. Thank you,
Thank you.
Dr. Pranay Desai and Madam
Thank,
Ramni
thank you
Devi.
for the
So we
opportunity.
move on to the next session.
Thank you.
So over to our youth council members, Dr. Richapal and Dr. Vijay, to introduce the chairperson and move on to the next session.
Yeah, moving on to the next session. I would like to now introduce our next chairperson, Dr. Nilima ma'am. She is a fertility consultant and gynec laparoscopic surgeon at a New Life Hospital and Advanced Fertility and Gynec Laparoscopic Center, Varanasi. Madam was the past chairperson, ISAR UP. She was vice president of UP IAG. She was the president Varanasi Menopause Society and past president of Varanasi Obstetric Gynecological Society. Madam is recipient of Shane Kashi and Kashi Ratna Awards. Over to you, ma'am. Welcome.
Thank you, Richa, for your kind introduction. So, very good evening to all of you. It was really nice listening to all two presentations, and they were really value adding. So, moving to the third talk. We have here Dr. Mala Raj. She is Vice Chairperson of IAG Tamil Nadu, Founder Secretary of IAG Tamil Nadu Chapter, Managing Council Member of IAG, and she has so many posts she has adorned: Vice President Chennai Menopause Society, Joint Secretary OGSSI, past Joint Secretary of Chennai Menopause Society. So it is looking good that
Yeah,
she
madam, yeah, we'll move
associated with
on, ma'am.
Menopause Society.
Madam,
Founder
we'll
and
move
Managing
on.
Director of Firm Hospitals, past so many posts
Yeah.
she has adorned, and she is trained in aesthetic gynecology, accredited menopause practitioner, and Best Doctor Award from Tamil Nadu, MGR University, Best Video Award,
It's okay,
Best
ma'am.
Paper Presentation, Operating Faculty, Suli Rudra Sinha Award, AICOG 2006, and Satyapal Award for Excellence in Minimally Invasive Surgery. So we know that she is an excellent surgeon. And so over to you, Dr. Mala. So we know that fibroids these are the commonest benign tumor of female genital tract, but sometimes they break the rule and behave uncommonly in their location, appearance, or clinical presentations, and in so many ways. So now the floor is yours.
Yeah.
So we
Thank you
want to
so
your presentation.
Yeah, thank you so much, madam, for your kind words. So can I share my presentation? Yes. Is my presentation visible?
Yes, it is there. Yeah.
So thank you, IIGE, for giving this wonderful opportunity to share my presentation on unusual fibroids. We now see many different types of fibroids. Of course, FIGO has helped us to classify fibroids in various types up to type 7. But then sometimes we get to see something even beyond this type 7. And these are the real unusual ones which we encounter in our clinical practice. So which we don't see them every other day. So we also get to see these multiple fibroids. This becomes a real challenge for us to perform the laparoscopic myomectomy, but then we need to perform because our patients want a keyhole surgery and they don't want any kind of an open surgery in such a scenario. So we have to evolve ourselves, and ever since Kurtzum demonstrated by the laparoscopic myomectomy, we have evolved quite a lot on our techniques, and also the technology has advanced in such a manner with the advent of all the energy sources and also the modulators. Now we are able to perform many of fibroids and multiple fibroids and the real unusual ones. So the first unusual one in my practice which I have encountered is the intravenous leiomyomatosis. It is a smooth muscle traveler inside a vein. So here, this is a case which of TLH where the fibroid was incidentally detected to be present in arising from the vascular pedicle. So it was not diagnosed preoperatively, but as I was trying to cauterize the uterine vascular pedicle, I saw a fibrous strand coming out from that vascular pedicle. Wondering what exactly it is, for a moment I got a shock whether I knocked off the ureters or what. Then I realized that it is not that, it is just that there is something else beyond it, and then this was a vascular structure which was coming from the vascular fibrous structure which was coming from the vascular pedicle. So decided to proceed with the TLH and then tackle what exactly it is. But it was just that I had read about a intravenous leiomyomatosis a few days earlier, and it so happened that I got to see that case in my own patient. So keeping that in mind, I proceeded with the TLH and completed it and made sure the hemostasis is all well secured, because I know once I remove this fibrous structure, there's going to be some amount of bleeding, and I need to tackle that because it is arising from the uterine vascular bundle. So after securing the hemostasis, this vascular structure was just pulled out from the vessel, and there was some amount of bleeding. So here you can see the ureters moving very beautifully lateral to that of the vascular structure. And then I decided to pull this fibrous strand out. So you can see that there is amount of bleeding which is coming from that, and this post-operatively histopathologically turned out to be a intravenous leiomyomatosis. And of course now it is very easy. That is the reason why I wanted to complete the TLH and tackle this. So now we have sufficient space and aram, so we can just tackle cauterize this pedicle. So the vascular pedicle is cauterized and hemostasis was secure. Okay, so now what exactly we need to understand when we have intravenous leiomyomatosis is that these intravenous leiomyomatosis can go up the vessels and go even up to the heart. So there are case reports where they have even done a cardiotomy and removed pedicles from the heart. So we have to be very careful and do a echocardiogram post operatively to see whether there are any kind of these lesions present in the heart as well. And the most important thing is we have to remove the ovaries for these patients, because we do not want any kind of an estrogen stimuli for these patients, because there is small little bits of pieces which have ascended up the vascular pedicle. They can continue to ascend if there is a hormonal support. So we have to make sure that we remove the ovaries. This patient had an ovarian cyst, as you saw, so I had to remove that in a bag and make sure her hormones are totally knocked off. So otherwise, there are reports where we have to also give GnRH analog post-operatively in these patients, so that there is no migration of these fibrous strands up the vascular pedicles up to the heart. So So this is a very unusual case of intravascular leiomyomatosis which I had encountered. Now, the second was the extrauterine fibroids. They are a smooth muscle surprise in the retroperitoneal shadows. So, this was in fact posted for an anterior fibroid, but then on introducing the scope, you can see that there was a mass arising from the lateral wall of the pelvis, and it had absolutely no connection to that of the uterus. So, here you can see that there is a groove between this mass and that of the uterus, and you have the ovary in between these things, in these between these two, this mass and the uterus, and also the ureters are going right below the mass. So this is a mass which is arising from the retroperitoneal region in the lateral wall of the pelvis. So this was again found to be a fibroid. So decided to just make an incision on the lateral wall and remove the mass, and it turned out to be a fibroid. So again here, when we are tackling such a huge mass, we have to be very careful of the vascular pedicles which are lying below these structures and ensure that they are not traumatized. So gentle dissection of these of the structures can help in enucleating these mass and do the procedure comfortably and safely without causing any complications. So you can see that at the end of the procedure, the entire bed of the myoma is very clean, and the peritoneum can be just left behind. So here you can see that there will be all the vessels which are lying below, and the ureters and the vascular pedicles are very safe. So this is a fibroid which arises from the lateral wall of the pelvis, and here you can see the uterine arteries and the iliac vessels which were lying in the bed of the fibroids. Next will be a large cystic cervical recurrent fibroid. So it is like a rare roadblock at the uterine exit ramp. So here, this particular patient, again, she presented as an adnexal mass. She was my old patient for whom I had done a laparoscopic myomectomy, and you can see that the mass was looking more like a cyst, and the preoperative diagnosis of an adnexal cyst was made. But on introducing the scope and manipulating the uterus, we found that this mass was arising from that of the uterus, that is from the cervical portion of the uterus. Can you see? That is the lowermost portion of the uterus, the cervix, and the mass was arising from that of the cervical canal. So it was a cystic fibroid. There was a question as to how we handle the cystic fibroid. So here you can see that so much, almost 1.5 liter of fluid was being aspirated from this cystic mass. And you can see that all these are the smooth muscle bundles. So after decompressing the cyst and sucking out all the fluid, then the myomectomy was performed. So the UV fold of the peritoneum was separated, the bladder was pushed and secured, and then myomectomy was proceeded. So here you can see that I am separating the mass from that of the bladder, and keeping the bladder well away from that of the mass. So a gentle enucleation of the fibroid is now happening from the bed, and you can see that it was arising from that of the cervical canal. So you can see that the cervical canal is now opened, and the entire mass is now being separated. So now we have to reconstruct the uterus. So little more, so you can see the uterine manipulator, elevator coming out through the cervical canal. It is always good to keep a manipulator or a dilator in the cervical canal so that we do not inadvertently close the cervical canal. So over that, the cervix and the uterus are sutured, and the uterus is reconstructed. So in that manner, the entire uterus is has got back its normal configuration, and the procedure is complete. So this is a large cystic myoma. So these cystic myomas, very important step is that always morcellate in a bag. So they are a huge one, but then it is a challenge to introduce them in a bag and morcellate, because these mass, while you're doing an open morcellation, they will fray all over the abdomen, and there is a chance for us to leave behind few bits and they can develop recurrent fibroids. So it is better to put them inside a bag and morcellate, so that it is a lot more easier, because we do not have to go and run behind these small little bits and pieces and remove them, because all these bits and pieces will be lying inside the bag, and we can just remove the bag with all those pieces, and it makes the job a lot more simpler. No, this is another very rare cervical kind of fibroid. So the plethora of cervical fibroids. So these are the gatekeepers which have gone rogue when the fibroids arise at the cervical crossroads. So generally we see one fibroids and maximum two fibroids, but here there were almost 6, 7 fibroids, like a bunch of grapes arising from that of the cervical portion of the uterus. Such a small little cervix having multiple fibroids, and the entire fibroids had its origin only from the cervix. So initially, even in ultrasound, it was detected only to be having these two fibroids. But as I started removing these fibroids, the multiple ones kept coming one after the other, like a mulberry. So here you can see I'm separating the UV fold and pushing the bladder well away and trying to enucleate the fibroid which was just visible. But then at the base, you can see there were multiple ones sitting there. Many mother, daughter, sister, grandmother, all kinds of fibroids were seated there in that small little cervix. So pulled one after the other, all the fibroids, delivered all the fibroids out, and then afterwards I transected and removed all of them one by one. So this is again a very rare kind of a cervical fibroid which I encountered. Generally, cervical fibroids are the challenging fibroids compared to all that other fibroids. But then when you have multiple fibroids, you have to be even more cautious and judicious that you do not damage the ureter. So keeping the ureter in mind, the procedure has to be completed. Here you can see the entire cervical canal was opened and the fibroids, all the fibroids were removed. So here again it was like reconstructing the uterus by connecting this uterus to that of the cervix. So once the fibroids are removed, we have to keep a dilator or a sound and make sure that the canal is not occluded, and the uterus now has become to its normal configuration. And of course, in-bag morcellation of all the fibroids were done. All of them were just gathered inside the bag, and morcellation of all the fibroids inside the bags were done. So now we saw plethora of cervical fibroid. Then this is another case where I saw plethora of submucosal fibroids. Here the uterus was itself transformed into a leiomyoma landscape. This particular case, she was from Canada. She had in fact gone for hysteroscopic myomectomy in Canada, but then they had deferred because they were not able to proceed with the procedure looking at the multiple fibroids which were present. So when this lady presented to me, I told her it's better we do a combined approach. So I put a hysteroscope and saw whether I could handle them hysteroscopically, but then that would kind of damage the entire endometrium. The base walls of the endometrium would be charred, and as a result, the women will develop Asherman syndrome. So decided to open laparoscopically the endometrium and remove all of these fibroids rather than charring the endometrium hysteroscopically. So there were almost 15 fibroids in the submucosal cavity. So all the 15 fibroids were removed one after the other by gently picking up with the myoma screw. So like a chopstick, all these fibroids were just picked up and all of them came out one after the other. So the major advantage of doing this particular procedure laparoscopically, that is, it is doing a hysteroscope through abdominal route, is like just we can make a small nick on the capsule of these fibroids, and the fibroids will make its way out. So you do not have to go and char the endometrium. Even a small nick with the harmonic scalpel, you can introduce the harmonic scalpel inside the endometrium, make a nick on the pseudocapsule of the fibroid, and you can say that the fibroids will make its way out. Most of them were even calcified. He had as big as 3 centimeter multiple ones. So all the fibroids were safely removed, and myometrium was sutured, endometrium was not sutured, adhesion barrier was laid, and the surgery was completed safely. Now again, leiomyosarcoma presumed to be a fibroid. So this is again a very rare case of, although the incidence of leiomyosarcoma is very rare, I have encountered 4 cases of leiomyosarcoma in my practice, and this is one of them where the woman was hardly 40 years and she came for a myomectomy, and post-operatively, of course, she was doing very well. The surgery report also came as a leiomyoma, but then luckily, that was the time when in-bag modulation was introduced, and I had done an in-bag modulation for this particular lady. And later, after 6 months, she comes with another recurrent mass in the abdomen, and it turned out, and we did an MRI, and it turned out to be a leiomyosarcoma. This was the first surgery which I'm doing. The second, when she had a leiomyosarcoma, of course, we were not able to offer her any surgery because it had spread, and of course it was very pathetic. We had to lose a patient also. But then this particular patient, afterwards, wherever she went for opinion, everyone said that it has to be only a post-operative diagnosis. And luckily I had done an in-bag modulation which saved my skin, because everyone said what is to be done has been done, because the doctor has put the myoma in the bag and also modulated it. So that is the reason why in-bag modulation has to be done, because it is not to prevent dissemination of leiomyomatosis, it is to prevent the dissemination of benign tissues, but at the same time, when you are in trouble, it will come as a savior. So leiomyosarcoma in abdominal wall operated for fibroid. So this is again another case where the patient had just a simple TLH for a small little fibroid, and after 1 year she had a mass on the abdomen somewhere near the inferior epigastric artery, that track. So after getting all the opinion and doing MRI, we found that there was no connection of this mass to that of the abdominal cavity. The mass was just anterior to the rectus sheath. So to our surprise, when I removed this mass, I had the help of a surgeon also for this particular case, because I was still not sure what exactly I'm dealing with, the mass on the anterior abdominal wall, and that HP came as leiomyosarcoma. So again, leiomyosarcoma, on discussion with our oncosurgeons and pathologists, we came to understand it can arise not just from the uterus, it can arise from any smooth muscular bundle. So this probably would have taken its origin from that of one of the vasculature, probably the inferior epigastric also, and then she has developed this leiomyomatosis. So because her pelvis was completely clean even at that point of time. So these are few, again, yet another rare case of a fibroid. Now, this is again another case where it presented as ovarian tumor. So you can see that a hard mass preoperatively, it was looking like an ovarian tumor, but surprisingly, all the tumor markers were negative. So, but then on introducing the scope also, there was so much of nodularity, and also the consistency of the mass was so hard. So I was very, very skeptical as to whether I'm dealing with an ovarian tumor. And if it is an ovarian tumor, I'm not going to proceed laparoscopically. So, but then if ongoing in depth, they found that it was a twisted torsion of the of fibroid. Okay, so this was a removed again. So these are the various presentations the fibroids can present. So again, fibroma of the ovary, again, this here you can see that it can also present in the ovary, and it did present as a fibroma. So again, this particular patient, we have to remove because it took its origin from the ovary. I had to give the specimen in toto, so I decided to do a colpotomy, put the mass inside the bag and delivered it vaginally in toto. So multiple small myomas, of course, we also this, though this is not rare, but this is one thing which I wanted to show, because when you have multiple small fibroids, sometimes even huge fibroids are okay, we will not miss. But the small little fibroids, while we are removing, there is a chance for us to lose them. So in such a scenario, it is always better to shrink these fibroids into a mala and then keep it aside and then morcellate it inside the bag. So in this manner, you will not lose the fibroids, and at the same time, your morcellation also becomes very easy because you make already you have shrunk that into a mala, and as a result, you have to just pick only the string and drop it inside the bag. You do not have to go behind all these fibroids one after the other and drop it inside the bag and morcellate. So here you can see that how I have made a string out of these fibroids. So as and when we are removing the fibroids, you can string them and park it onto the anterior abdominal wall or paracolic attack. So here you can see, you can just pick up just that one string and all the fibroids come into the bag. You do not have to go behind each and every one. So this is again a very nice one. So lantern on St. Paul's Cathedral, again, this is a very rare one. We have a small little uterus sitting near the umbilicus and a huge mass occupying the entire pelvis and the abdomen. So here this was, I did a hysteroscope to make sure whether I'm dealing with, so here, can you see that small little uterus, which is sitting near the umbilicus, and the entire lower segment was the fibroid. So this is again a very challenging cervical fibroids because you have a fair chance to injure the ureter. So we need to meticulously dissect and also safeguard the ureter and remove these fibroids. And of course, after that, I had to reconstruct the uterus. The entire uterus and the cervix were almost parted. So you have to reconstruct them and bring the uterus back to the pelvis. It was sitting near the umbilicus, so we have to bring them back to the pelvis. So this is again a very interesting case which I had encountered. So these are the this is again this is the same one, yeah. So large broad ligaments are fibroid. This Kiran Koilo madam has demonstrated, where again broad ligament fibroids, again these occupy the entire pouch and the pelvis. Port side fibroid, again, this was pre-open open myomectomy, meaning without in bag, the days when I had done some of almost 10-15 years ago, and the patient came back with a small little mass at the port site. So these are the reasons why we have to do an in-bag modulation. So this is the port site myoma, and of course I had to remove that now. And so large submucosal fibroid. So when you have a large submucosal fibroid, so again, it is not necessary we have to do only hysteroscopically, because sometimes in these cases we have to do them in 2 sitting procedures, so the patient will not be happy. So in such cases, do a hysteroscopy, identify the base where exactly these submucosal myoma come in, and then that is to decide where exactly we need to make a nick laparoscopically, make a nick on the prominent portion and see where exactly the fibroid is placed hysteroscopically, and then you have to enucleate there. So this is laparoscopic myomectomy for a submucosal myoma. So again, here the myometrium is being sutured over the endometrium. So, and the barb suture have made our life a lot more easier, for not only just for the ease of suturing, but the various advantages associated with the barb suture. So this is again a large cervical fibroid arising from the cervical canal post LSCS, that is from the cesarean scar site. She had an LSCS, and then she came back with a huge mass, which where I found that there was a fibroid which was arising from the cesarean scar site. So that fibroid was now removed, and again so cervix opened. Okay, so cervix was totally open, and then we had to reconstruct the cervix. So these are the many fibroids which we have encountered, and of course, various other things, the cervical fibroids which has undergone degeneration. So sometimes you can undergo see fibroids like this, and you're not necessary that you will get everything in total. So this is because of the era of medical management. When they go on medical, that was a discussion which happened with Kiran Coelho madam. So here I'm opening the lateral pelvic wall and keeping the uterine artery at origin, so that open, so that if there is any need, I will ligate it. So I just went ahead and so here ligation is done at the isthmus, the uterine artery also, and then you can see this degenerated fibroid. So in this cases, it is like doing an in-bag in situ modulation. It came out only in bits and pieces. These are the drawbacks when you do medical management before surgery. So you have to put them all inside a bag, all the small little pieces. There's no rule for modulation because the removal itself was like modulation. So these are the, of course, sometimes you can also encounter fibroid in the round ligament. Of course, the various site, wherever there are smooth muscles, it can still come. And then 20-week cystic fibroids. This again, as there was a question, how do you handle the cystic fibroids? So here, these 20-week cystic fibroids, again, if you see here, you will not be able to use a myoma screw. You will not be able to give any kind of attraction. So gently, you have to just, dissect them out, and either with a valsalum or a tooth grasper, and then dissect them out. So these are real cystic fibroids, where the entire cystic fibroids have to be dissected. And here, so these are the right cases. Here the entire fibroids are dissected and the base, and you have to do a in-bag modulation, because again they will cause dissemination if you are going to do an open modulation. So all the fibroids are, see, you can see at the end how much of fluid and the tissues are left behind in this fibroid. So these will have sprayed all over the abdomen, and you should have run behind these tissues to make sure that you are not leaving behind any bits and pieces. So it's an advantage of in-bag modulation, where you can just, safely modulate it in, because as you're modulating, you will see that it is very tough to modulate these cystic fibroids, because they will be so friable, you will not be able to catch the tissue and modulate also. It is a challenge even inside the bag. Sometimes adenocarcinoma of the cervix, which was thought to be a cervical fibroid, again in a young 30-year-old lady. So this one presented as a cervical fibroid, but pathology reported as adenocarcinoma of the cervix, which is again a very rare presentation. So thank you so much. So these are the various uncommon ones which I have encountered in my practice, the unusual fibroids. And so with this, I come to the end of my presentation. And thank you so much, IAGE, for this wonderful opportunity.
Dr. Mala, it was really very interesting and excellent talk, and you have just collection of such cases. It was really mesmerizing. So many
Yes.
types of fibroids you told, and those were beyond this FIGO classification. Even FIGO could not catch them, and you found them all. Like intravenous leiomyomatosis, it was really excellent. I was wondering how the blood supply was coming or going to that part of the body. And then extrauterine fibroids, cervical fibroids with cystic changes, submucous fibroids. So many times we have to take decision at the time of surgery that no, we are not going through hysteroscope. We are going to, because that will be more giving more harm to the patient rather than going to laparoscopy. And at the time of entering into the abdomen and at the time of operating upon that fibroids, you have to take decision. That is the most important thing, that how to deal with that particular fibroid. And at the same time, diagnosis is very tricky, very challenging. So that is why most of the time we need to have MRI in such cases, though we rely on our ultrasound much because we do our own ultrasound. But many times it is said that Dr. Shrikant always says that why you haven't did not have MRI in this particular case. So I used to say, no, I rely on my ultrasound, but later I realized in Some cases MRI is a must. So high suspicion has to be there that it may be a unusual type of fibroid. And you enumerated so well, so many types of fibroid. So it was really nice learning for all of us. And what I was particularly seeing that in every case has a different type of challenge, and your clinical acumen and surgical acumen and your all experience, they all put together, then only you can handle a case. So very nice.
Thank you, thank you, thank you so much, ma'am, for summing up. Yeah, Dr. Vijay Kumar, you have something? Yeah, yeah.
Ma'am, in that case, you have removed 15 almost submucous fibroid. What
Yeah.
precaution did you take while suturing? Means
Suturing, is it? Then,
yes.
no, because the nick on the endometrium was a very small one. I did not suture the endometrium. Then regular suturing in layers only I did. So myometrium was sutured in layers, that's all. Actually, I think that time even barb sutures were not there. So this is one of my oldest video. Yeah.
Oldest video. Okay.
Oldest video. It is
Very
not the
nice video.
recent one. Yeah. So in fact, it was on Diwali Eve. Yeah, I was caught because I didn't have anyone in my OT, me and my staff. Just the two of them of us operated on this particular lady because she had to go back in a week's time back to Canada. So it was a real challenging situation, but she did so well. Yeah, and she came back also after that.
Because I had seen 2, 3 fibroids or 4 fibroids maximum in submucous cavity.
Yeah, yeah, correct. Yeah.
15 fibroids in.
Yes.
Nice.
That is why in Canada also they had put the scope and then they stopped. They abandoned the procedure. So she
Okay.
was so upset. And then somehow she found me and she came. I told her do MRI and come. Then looking at that, I said, this, in fact, that was my first case where I have also done a combined approach. So that particular thing, I just decided, okay, this is way I'm going to handle it, and then it came out well. Yeah.
Nice.
So the most of these unusual ones, no, as Madam said, you're caught in by surprise. It is not that you have a proper preoperative, diagnosis. You are having some other diagnosis in mind, and when you go and see something else, that point of time we should decide and work. We should have that frame of mind to decide and
At that very time, you have to take decision.
yeah, so we don't, time is not in our favor because we are already there inside. You cannot, say, okay, you cannot say you are going to cancel the case or something. You have to complete the procedure. So what best you can do to complete procedure, we have to. So various, that is why all these webinars, I think, help because when you see multiple people operating and multiple cases being shown, no, somewhere it will register in our mind.
Yeah, that's true.
This intravenous leiomyomatosis, I wouldn't have known if I hadn't seen that particular paper. Just randomly, came across that paper and I knew maybe something like that is what I'm seeing now. And it was so, I was so fortunate that the biopsy also turned out like that only. That's how it works.
So there are two questions. One is for a 5 to 6 centimeter myoma, what volume of vasopressin you inject and dilution you prefer?
Yeah, 5 to 6 is actually not a very huge
Not very big,
fibroid.
yeah.
So just hardly 10 ml of saline is what is needed. So 10 units into 100 ml of saline is more than enough. Vasopressin, yeah.
Which barb is the best, uni or bidirectional, and number of barbs?
Yeah, so barbs as such, both are quite good. The only advantage is that unidirectional will be just having one needle and you can come start on one end and finish it off. Bidirectional has two needles, so it is the suture length is going to be long and you start in the middle. So when you have a huge fibroid, suture line to be sutured. So from you start from the center and then go in one direction and complete it with one needle, and the other direction you go and complete in the other side. So only thing is which makes a difference is the way the barbs are being placed in this in the suture. You have spiral barbs and you have symmetrical barbs. That is where the difference come. And you also have absorbable barbs and the non-absorbable barbs. These are the factors which we need to consider like while using barbs. See,
Yes.
but in a certain large myomas and all, where the bed is going to be a large one for suturing, I prefer to use the symmetry barb, wherein the barbs will be like a fish bone. They will be like just facing each other, opposite to each other. So like they are symmetrical barbs. They come from the Ethicon company. So they are the symmetrical barbs. But the other barbs, if you see, they are the spiral barbs where they are like they comes in spiral form. So both are very good for anchorage. But when you have the symmetry barbs, when you have a large bed and we are going to use only you have 30 centimeters, 45 centimeters. When you use a long suture material, the hold anchorage is a lot more better in the fish bone. That is a symmetrical barb. That is why I prefer symmetrical barbs while I'm having a large myoma. And another advantage with these symmetrical barbs would be they have a tab. Okay, these barbs, they have a loop right at the end where you pass your thread and come out. But in these symmetrical barbs, you'll have a tab. So you don't have to even, pass through the loop also. You can just bury the tab and then do the entire procedure, suturing. That's the difference, madam. Otherwise, barbs are
Yeah.
quite good. But only thing is like try to avoid too much of exposure of the barbs. That is why we always advise, the baseball stitch at the serosal portion so that all the raw areas also goes inside and these barbs are also not exposed much. And as I mentioned, when I have a case like this, I'll also like to put an intercede so that, these barbs also do not expose too much.
Yeah.
Ma'am,
So there are no other questions in the question answer box.
ma'am,
So
excuse me. One last question, ma'am.
Yeah.
I mean, 3-4 cases in cervical fibroid cases, cervical cavity is open. Then you suture the cervix. Then what precaution did you take to avoid post-operative stenosis, cervical stenosis?
Yeah. So
You put the
that is why I always put that manipulator. No, my uterine manipulator will be there. Manipulator meaning it is like a sound with a valsalum. So it holds on to the cervix and also you have a sound which goes inside. So once the canal is patent while you're suturing, then I think after that you don't require anything else. You don't have to put any kind of a Foley's. Don't no, not needed at all. It is a nicely developed and functioning uterus. You have to just make sure that the approximations are. It is not an anomalous uterus where there is not patency is not there. So it is a well nicely developed functioning uterus.
Yes.
So it was good that all the cases you do it laparoscopically, you don't have to convert it in laparotomy in all these difficult
No,
cases.
all these cases I never converted, madam. All these cases I have completely done laparoscopically only. But again, you should not go with an idea that conversion is a failure. What you should understand, so in certain scenarios, of course, these cases, what I showed, it's all you saw, it is lab. But then if you convert, don't consider it as a failure because the best interest of the patient, certain situations, you have to convert, like how Kiran Koila madam showed, some 50 fibroids where she removed. So where you have multiple seedling ones and the thing in a young girl, I think in such a situation, it is a good, wise advice to open and do it because this comes only with with a period of time or experience. That is wisdom. So in such situation, it is good to open and also remove all of this fibroid because with one incision you will be able to do multiple ones and also saving the uterus and rather than having recurrent fibroids and the girl or a women coming in for multiple times.
Okay, fine. Thank you, Dr. Mala. Very nice.
Thank you, ma'am. Thank you so much. So we have come to an end.
Yes.
Yeah. Okay, fine. I think all questions answered also. Okay. So thank you so much,
Thank you.
Dr. Vijay Kumar and Neelam Madam for this session and interacting well. And then I think we covered most of the aspects of fibroids in this particular webinar. And I would like to thank our President, Dr. Kalyan Bambade sir, and Dr. Sujal Munshi for giving us this wonderful opportunity. And over to Dr. Sujal Munshi for the vote of thanks, Honorary Secretary of IAG.
I hope I'm audible.
And birthday boy.
Yeah, birthday boy. Sorry for
As
holding you
usual,
back on your
a
birthday.
wonderfully conducted episode once again, eighth in the series. We are really proud of Mala Madam for conducting this beautiful seminars every month. And you saw in this past 2 hours, we had a lot of good interaction. Some of the great speakers, very good compilation of cases, and experts sharing their knowledge on this. So we are also thankful to Shield Pharma for giving this platform to share these ideas. And under leadership of Kalyan Bhai, this probably is one of the last few webinars, but we had wonderful webinar series throughout the year. So thank you, Kalyan Bhai, for making this happen, and congratulations to Mala Madam for making it happen in the way it should be. Thank you.
Yeah.
One more will happen in February, don't worry.
Okay,
Yes.
I'm not ready to leave. Okay, good.
Mala is very fond of fibroids.
Yeah.
She did
Yes, I like fibroid a lot.
conference on fibroid and then
Yeah. Thank you, IAG. Thank you, Kalyan Babde sir and Dr.
Thank you,
Sujat.
Neelam Madam. Thank you, Ramala Devi Madam, for
Yeah.
coming here.
It is my
And thank you,
honor.
Dr. Vijay and Dr. Richa for conducting so
For
nicely.
wonderfully conducting it.
Thank you.
sir.
Thank you, Dr.
Thank you,
Vijay
sir.
and Dr.